consumers don't always get to have input into major health system transformations. Under Donna Kinzer, she has. She's created 2 task forces. I'm the chair of one. Lenny Preston is here as the chair of the other. And what we're doing is reaching out to the public and seeing what the public thinks of what's going on, educating the public, and with you talking about ways that we can work together to make this health system transformation work well. So why don't we start by listening to Donna Kinzer tell us about what's happening. Let's hear from Donna. Donna?
Thank you. And just want to make sure we get the microphone position good here. Thank you. And I want to tell everyone that I'm really honored to have the opportunity to be serving you during such an important period and time of change. It is my honor. And I also want to just recognize that I have Jessica O'Neill here in the audience from the Health Services Cost Review Commission, who's really been helping with all of our work groups and gaining input from the stakeholders. And Jessica's about ready to go off to medical school, so she's had a real experience being involved in such a big change here in Maryland. And in terms of what we're headed toward here, when we signed the legislation back a few years ago, there was a lot of excitement. But then last year, when the exchange started in Maryland and around the country, all eyes turned to the exchange, and people started thinking that Obamacare was just about the exchange. And we had our travails here in Maryland, but we're up and running. But what I want to tell you is that healthcare reform is about a lot more than the exchange. And it's about the fragmentation that we've been experiencing in the healthcare system. It's about health disparities, where we have people, even though we have a life expectancy of close to 80 years old in Maryland, we have large population groups in Maryland who are dying in their 60s. It's about the aging of the population, the aging and sicker population that we have now, and that population that's growing. And it is about coverage and access. And I'm going to quit hitting that clicker there. It's about coverage. It is about coverage and access also. And that is where we've gotten into the exchange, and we've been very fortunate in Maryland to have such a major increase in the enrollment and people now covered in Maryland. And we're seeing the results of that now in our data at the Health Services Cost Review Commission, and we're seeing people who couldn't get surgeries before now getting surgeries, for example. So it's exciting to see the results in the data, and I know that you hear them firsthand. It's also about how we need to change the workforce to deliver care in new ways. And last but not least, about how we're going to afford health care in the future. In switching to some particular areas that are really driving a lot of our thought process and conversation. We have the aging of the population at the top of the list, and over the next few years, we'll be moving from a recent population of 40 million seniors over 65 to one where we have 72 million people over the age of 65 in 2030. And I was thinking at first, well, 2030 is way out there, but really it's only 15 years from now, and we're talking about me when I'm hitting 75. So I want to make sure that I've got the system going for me when I get there. And at that point in time, in 2030, 24% of our population will be over the age of 60 in the United States. Now, and I'm not going to try to make you read or listen to all of that detail on the right side of the chart about the economy and the implications for the economy, but the bottom line is that all of our federal budget is taken up with health care, Social Security, and defense. And as we have an increasing number of people on Social Security as they're going over that 65 mark, what that means is that there are fewer taxpayers because we have more of an aging population. So that even puts more pressure on our federal budget. So we have cost increasing for seniors and we have fewer taxpayers. So we really need to do something from the economic and affordability standpoint. And of course, going into that picture, what we see is that if we look on the left-hand side of the chart, we're looking at the U.S. spending growth, and we can see that that has outpaced all of the other developed countries in terms of the growth and the cost. And we're also spending a higher proportion of our gross domestic product on health care, but the outcomes are not better. Our life expectancy is not, it's in the bottom part of the developed countries, not the top. We have a lot of healthcare outcomes, particularly those relative to chronic care, where our outcomes are not as good as other developed countries. So spending more and not getting the outcomes. And that really turns me to the topic of chronic conditions, because this is one of the areas where we can really make an impact going forward in terms of making lives better, as well as addressing spending issues. So as we start looking at the picture in front of us, we have 14% of our Medicare beneficiaries, and that 14% has 6 or more chronic conditions, and that 14% accounts for 1/2 of Medicare cost. And those formulas also work as you move into the younger population, the 50 and over as well. But the story underneath that is not that there's just 14% with that many chronic conditions, but about the real prevalence of chronic conditions in the over 50 and the Medicare population. So if we start looking at that a little bit, and what we find is that 27% of Medicare beneficiaries have diabetes, so close to a third. And it's even more prevalent in Maryland. So the top line is the Maryland line, the bottom line is the national line. And I've kind of circled Carroll and Frederick counties here for you so you can see your county prevalency. And you're right around the national average, just a little bit below the Maryland average, but that's a third of the Medicare beneficiaries. Then, if we look at another chronic condition, 45% of Medicare beneficiaries have high cholesterol. Again, the top line shows you that it's more prevalent in Maryland than the national average. And what we see is that Carroll and Frederick are actually a little bit higher than the Maryland average on those chronic conditions. And turning to a third one, 55%. So we're not talking about someone else. We're talking about really all of us, because more than half of us, as we hit the Medicare beneficiary list, have high blood pressure. This is more prevalent in Maryland, and Carroll and Frederick are similar to the Maryland experience. So all of these conditions are very common, and they drive a very significant health cost, and also drive conditions, bad health conditions for our population. So this just begins to lay some foundation for the thinking that is going into the implementation of the new programs in Maryland that we hope to have unfold over the next couple of years. And you all in Carroll County and are ahead, because you've been thinking about it longer than many other parts of the state. And Frederick is also very advanced in its thinking. But where we're headed with this is to really focus on improving the health of the population, improving the patient experience, and reducing the per capita cost, so that if we focus on the things that can actually improve health and care, we are expecting those to have we're expecting to reap the benefit and also lower cost. And the focus and the way that we're headed to go about that is in our, as we're thinking about this in the course of over a couple of years, and Kevin kind of talked you through this same thought process that you've been going through here in Carroll County with the TPR model. In the first year, we're really trying to shift to a consumer-centric approach, a consumer-centric model, so that we're focused on the patient and the patient's needs and the patient's care. And we started our model in Maryland really focusing a lot on care transitions. So what happens with a patient when they go from the hospital to home? How do we make sure their medications are straight, that they know which ones they're supposed to take between the hospital and their doctor? And then the other thing that we have focused on in the first year is changing the payment model. So Kevin told you about how changing the payment model really freed up the hospital staff and others to think about new ways of delivering care. So that's what we're focused on in year one. In year two, we're really shifting now and focusing on ways to modernize the services to match the new model. So how do we change the delivery system to actually deliver better population health and better chronic care? And that really requires us to get together and partner with the hospitals and the physicians and other providers, the mental health providers and the communities and the consumers, to really begin to develop this model in a way that it will work better to produce the results that you want. And then we have to implement all of these new models and changes and continue to improve the models with a real focus on that chronic care that we talked about. Working with people and patients to keep them healthier. And we're focusing on health just not only from physical health, but also financial health to get the cost in line with where they need to be. And very importantly is engaging communities in the process of making that happen. And so that's part of what we're here for today, is really to make sure that we're starting that engagement as early as possible in the process. So just to step back and put a little bit more meat on the bones of what we're doing from a payment standpoint, what we're doing is moving payment away from fee-for-service, where the more you do, the more you get paid, to a system that focuses on the better you do, the better you get paid, with the providers assuming more responsibility for outcomes. So the providers assuming more responsibility for reducing hypertension, reducing cholesterol, reducing the diabetes out of control. So really providers taking on more of that responsibility in this process. And this does drive a need for more integration and collaboration. And I think, as you all heard at the beginning, that this is a massive change in approach. It's a 180 of how, looking at how we're going to deliver health care. And we need everybody engaged with us to make sure that we're doing it right and it's working as we expect. So just to even step back a little bit further, so I'm from the Health Services Cost Review Commission. You heard that at the beginning of this, but what does that mean? We have Maryland has had hospital rates set since the mid-1970s by the Health Services Cost Review Commission. It's an independent 7-member commission. It acts like a public utility, and it provides oversight and regulation of hospitals. And Maryland is unique in the country in that the rates that we set are paid by all payers. So Medicare pays out the rates that we set in Maryland. Well, that doesn't happen in any other state. In every other state, Medicare sets its own rates, but here in Maryland, we have a special waiver that allows us to set its rates, as well as the rates for all the commercial companies and Medicaid, etc. This has a tremendous value, and historically it has helped to hold the cost down in Maryland relative to elsewhere. But also, we were able and are still able to fund access to care for those who do not have insurance through this program at the hospital. So patients could be covered at the hospital for services even if they didn't have insurance. And it would be covered by the payment rates that we set for all payers. And it's a very transparent process. So I don't know if any of you have been in other states, but the charges and the costs are a lot different. But in Maryland, the charges are quite low compared to hospitals in other states, and the process is very transparent. We've also been able to start earlier into quality improvement programs because we had everyone on the same page and doing the same thing. It was much easier to initiate hospital quality payment programs in Maryland, and we've been very successful with that, getting ahead of the curve. And even in the last several years, we've had a 30% increase in the quality indicators for the Maryland hospital. So it's really been successful in terms of being able to move quickly down that road. And last on this list is local access to regulators. And what that means is that if something isn't working or needs to be changed, we can do that very quickly here because we're local and agile. It's not a 2-year wait until the federal government figures it out, etc. We can act locally. So we've had this rate setting authority for a number of years, but on January 1, we just started a new model with Medicare, and it's a 5-year model, and the focus of the model is to focus on holding down the cost in Maryland, as well as more rewards for improving outcomes, so that there's more rewards when the patient results are better, and that the focus is on encouraging better teamwork across the whole system to improve the coordination and experience across the whole system. So what are our expectations, and what does that mean for patients? What do we expect from this system? What should you expect from this system? What we will be doing and have already begun is to make quality, safety, and customer satisfaction scores account for a significant and growing amount of hospital revenue. So those are the rates that we're setting the hospital. So that is requiring hospitals to become more patient and family-centered in their approaches to be able to gain the revenues that come from those higher scores. It also requires, and you should expect to see a much greater emphasis on care coordination. So how, and I'm sure all of you could have a negative experience that you could report about care coordination, but you should really expect and demand and see a much improved emphasis on care coordination. So when you go from the hospital back to home, or your family member, or from the hospital to a nursing home, that there are handoffs between the providers, but also handoffs with the patient to make sure the patient knows what is expected in that process. You should expect more outreach from the hospital and the providers in terms of, especially with those chronic illness. So with the new technology, every time you come in the office, if you have high blood pressure, somebody should be checking in with you to make sure that you're addressing that and taking medication, and really focusing on minimizing the impact of your chronic conditions. Also really focusing on getting people to the most appropriate setting. So the best setting is if you can keep it at the doctor's office level and get treatment early and not end up at the hospital. That's obviously the very best result for the patient as well as for the cost to the system. So that's a really very significant emphasis. And hospitals are being measured on their success of working with the community providers to make that happen in our new model. So that's really important. So in terms of where we're headed, the new waiver really is a call to action. How can we make this delivery system work better for us? How can we pivot 180, as you said, and make this work for us? The model that we've created here in Maryland is less disruptive than other parts of the country in doing this because we are all payers. So we're doing this as one model and not having a confused process where we have multiple models that we're trying to navigate, but one model. And And we're doing it very proactively in terms of setting goals relative to the improvements that need to be made to produce the results that we're trying to produce in terms of better care. And really setting the agenda for value, and hopefully doing that together with you, the agenda for improving the quality of having appropriate hospital care and avoiding hospital care that could be avoided if we had more coordination and better integrated care with the community. And doing this really in a way with new partnerships with physicians, partnerships with long-term care facilities, and partnerships with patients. With the focus of really getting that cost efficiency and the population health improvement as an end result of this new model and its implementation. So I thank you for the opportunity to talk with you and really to take this journey together with you, and hope to work closely with you during the process of implementation.